Dr. Mahesh Shanmugam. Probably he's the best one to speak on surgical management of proliferative diabetic retinopathy. Currently, Mahesh Shanmugam is the chairman scientific committee with the Retina Society, and he is the founder of RetNet India.
Thanks, Dr. Ajit. This talk is on surgical pearls and diabetic vitrectomy. So let's start with the indications of diabetic vitrectomy. Of course, we don't want to do a vitrectomy in diabetics. If in case like Dr. Kim and Dr. Manisha and others have their way, we will not be doing a diabetic vitrectomy at all if we screen them in time. But then we do get a significant number of diabetics for vitrectomy. The traditional indications are non-clearing vitreous hemorrhage, traction retinal detachment involving the macula, and combined retinal detachment even if the macula is not involved. Because combined retinal detachment is like a regulatory retinal detachment. It's a macula-on detachment, we still go ahead with the surgery. Earlier teaching used to be that we wait for 3 months, waiting to see if the vitreous hemorrhage clears, and if not, we do surgery, but then we don't wait for 3 months anymore. It has been shown that early surgery, particularly in type 1 diabetic, yields better results. And if there are no contraindications, I would wait until a month. Contraindication in the sense if there's no secondary glaucoma, if there's no traction retinal detachment on an ultrasound, I would wait for a month. If it doesn't clear, we'll go ahead with the surgery. Now let's start with the point number 1. Indications have expanded as far as diabetic vitrectomy is concerned. Even if there is an epiretinal membrane which is causing macular distortion and a cystoid edema, then we go ahead with the surgery. So this is a slide which you did see earlier in one of the presentations. So proliferative diabetic retinopathy with a thickened posterior hyaloid, which is resulting in diabetic macular edema, is not going to resolve with injections and needs a vitrectomy. So this is how we go about doing a vitrectomy. You can hardly see an epiretinal membrane, but then we do a vitrectomy, induce the posterior hyaloid, and then once we are able to peel, induce one small nick in that epiretinal membrane, you can see such an extensive epiretinal membrane which is invisible was there. Then nowadays we do go ahead peeling the internal limiting membrane so that they decrease the risk of a secondary membrane formation as well as the macular edema results better if you were to peel the epiretinal membrane, but the internal limiting membrane. But of course we have to be careful not to deroof the cystoid edema. Another indication would be a vitreopapillary traction. This is a ill-defined entity in the sense that the traction is on the disc. So you may see a disc edema because the posterior hyaloid is pulling on the disc. So here we peel the hyaloid from the disc, then the stasis in the disc decreases and these patients improve in vision. So here you do have an epiretinal membrane as well as traction on the disc. So not that we jump in and do surgery in these patients, we look for a disc edema as well as we do a serial VEP to see if the VEP is subnormal, or if there is a progression of vision loss, then we go ahead doing a surgery. So this is how things can be. It looks like as though there is no epiretinal membrane at all, but there is actually a taut posterior hyaloid which is causing this extensive exudation. And post-vitrectomy, you can see how well the exudates improve and the patient's vision improves. Asteroid hyalosis, which precludes a PRP, is also an indication for doing vitrectomy, so that we're able to do the laser photocoagulation, which the asteroid is preventing it from. Other indications are dense premacular hemorrhage, hemolytic glaucoma, recurrent vitreous hemorrhage, and antihyaloid proliferation. Pearl number 3 is if there is an extra macular traction retinal detachment. As you can see, the detachment is here and the fovea is spared. Best is to watch, because this is an extremely difficult surgery and there is a possibility that this patient will lose vision following surgery. Wait to see if there is progression and decrease in vision before we operate. So what is the risk if we decide to wait? So risk of macular involvement in extramacular traction retinal detachment, as you can see, is about 14%. And the larger the size of the extramacular traction retinal detachment, more is the risk that it may progress. So larger the size of extramacular detachment, we tend to follow these patients much more closely to see if it moves towards the macula. So what is the role of anti-VEGF? Yes, it eases out the surgery quite well. So it decreases the risk of bleeding and the surgical process is much better. But then we have to operate within about 3 to 5 days after injection. Otherwise, there is a possibility of this detachment worsening rapidly and becoming a combined retinal detachment as well. I don't use them in all the cases, and anti-VEGF can be used at the end of the surgery, and studies have shown that the recurrent vitreous hemorrhage after a diabetic vitrectomy is much lesser if we leave the eye with an anti-VEGF agent. Disadvantage is it adds to the cost, and we still don't know if these anti-VEGF agents add a systemic risk factor like cardiovascular events or CNS events, so that's something which is not clear as well. Moving on to vitrectomy and proliferative diabetic retinopathy, one of the pearls for the budding surgeons is more fundus details we are able to see, more difficult the surgery. That means like there's no hyaloid separation. Hyaloid separation induces vitreous hemorrhage, which is not there, then more difficult the surgery. But on the other hand, if there is vitreous hemorrhage or subhyaloid hemorrhage, then that means large amount of the hyaloid is separated, so it's easy to do the surgery. So the steps is do a core vitrectomy, then make an opening somewhere, and then drain the subhyaloid hemorrhage, then truncate the cone, then take the rest of the cone posteriorly, and that's the small bit of fibrous tissue at the disc which is removed, and surgery is complete after laser photocoagulation. Pearl number 7, so induction of posterior vitreous detachment is different. Here what we see is a macular hole on epiretinal membrane. We just go there, do a core vitrectomy, hold the vitreous at the disc, peel it off, just pull it off, and then cut the vitreous and do it. But on the other side, you see a proliferative diabetic retinopathy. We are not able to induce the posterior hyaloid separation, so you make an opening in the posterior hyaloid, then very gently tangentially peel everything. So and here you can see that there is a pull on the fovea, which is again tangentially being pulled so that like we don't cause a bleeding or cause a break. And we see these little nodes. These are all NVE or fibrous tissue proliferation. You can see how we are not pulling off the hyaloid directly there. We're gently lifting it up and circumcising it, going around and making the fibrous tissue fall flat and then tangentially removing it. So that's how the induction of PVD is different. Though you would see people going ahead, like holding it at the disc and pulling it off like how you do in a diabetic, in a macular disease. This is a much safer way of doing induction of PVD in diabetic disease. And pearl number 7, always look for a second membrane. So this is not the end of the proliferation, this is the end of the proliferation. So look for a second membrane and dissect underneath that decreases the risk of, you can see how it peels off. The second membrane, in a circumferential manner, if you peel it towards the fibrous tissue, all the vascular nails are exposed beautifully, so we are able to cut very easily, and the risk of an iatrogenic break as well as bleeding is much lesser if we operate under the second membrane. So here you can see that like we're pretty much able to complete the surgery with the cutter itself, though I don't have a cutter fixation, but if you operate under the second membrane, we can pretty much remove all the fibrous tissue quite safely with this itself. Segmentation, delamination are old concepts. We don't separately do them. It's a continuous flow of the surgery now. So you could see that like I peel the second membrane anteriorly, then now what we are doing is segmentation, now we are doing delamination. Earlier we used to do delamination with the scissors, but we are now delaminating with the cutter itself. All this is possible if we operate under the second membrane. Once again, you can see that is the second membrane, which is invisible, extending anteriorly from the fibrous tissue. So we move it towards the fibrous tissue. And now the retina is still bullous, so we drain the fluid, make the retina a little flatter, and then go ahead removing the fibrous tissue. So there are many ways to skin a cat. So some people start at the disc and then progress anteriorly. I usually prefer to do a truncation of the cone and then progress posteriorly. Here I am trying to induce the hyaloid separation. You can see the hyaloid is very, very densely attached and there's no separation at all. So then somewhere we made an opening and then we do a bimanual dissection. So if it's extensively adherent like this and there's no hyaloid separation at all, then I would jump in to do a bimanual surgery. So the forceps is being held in the left hand and the scissors in the right hand, but then like we need to be reasonably ambidextrous. The forceps job is to just lift up to show us the vascular nail so that we are able to cut with the scissors and not to pull the fibrous tissue off. So here in this area, there is still no, inferiorly, there is still no hyaloid separation anteriorly. So that once again, like very, very gently, we lift it up, identifying all the vascular nails and then removing it. And that's the last bit of the tissue at the disc, and we've removed it. Now we identify the break, do a fluid air exchange, reattach the retina and do laser photocoagulation. That will be the end of the surgery. So as I mentioned, I usually do surgery from outside in, but here there is no separation at all. Once again, there is absolutely no hyaloid separation. So we open the funnel in the posterior pole, Even then what I do is like once I pull the fibrous tissue at the posterior pole doesn't mean that like I completely pull it off and then like I take it once again anteriorly, then come around back to the posterior pole. That's how I prefer to do the surgery, because posterior pole you have sensitive structures like the disc and the macula, and you don't want to create a break there. And if it bleeds, once again it bleeds massively in the posterior pole, making the surgery very, very difficult in these eyes. So I usually start peripherally. Outside in is what I prefer, but if I do inside out, once again, like I start inside, go out and come back inside. So these are all combined retinal attachments. As you can see, this is the last bit of the fibrous tissue which is being removed. Reattach the retina with fluid air exchange, oil and laser. And here this is one extreme case, long-standing like TRD which became a CRD. This is a one-eyed patient and extremely ischemic retina, and we see extensive subretinal bands as well. So with very, very meticulous dissection, because like one little bit more pull on the left hand, we will tear the retina, and this retina is going to be extremely difficult to reattach if we have a break. So now nearly about like half the fibrous tissue across the retina has been removed. Rest of it is being very carefully removed, and that's the end of the surgery. We left this eye with PFCL initially. And what are the anatomical results? So traction retinal attachment, in about 95% of the patients, if we do the surgery properly, we'll be able to attach the retina, and vision improvement is in about 70% of the patients. Combined retinal attachment is a pre and post-op appearance of one of the patients. And eyes which look absolutely hopeless also do improve if the surgery is done properly. Complications can be cataract, retinitis hemorrhage, retinal detachment, anti-hyaloid proliferation, rubiosis, iritis, and neovascular glaucoma. To summarize, more one can see, more difficult the surgery. Extramacular traction retinal detachment can wait until it progresses or causes vision loss. Operating under the second membrane decreases the risk of breaks and hemorrhage. Need to create a roadmap for each case and then follow it up wherever possible. And if done properly, gratifying results are what we get in return. Thank you so much for your kind attention.
Thank you, Mahesh. It's a very enlightening presentation. I have seen all the indications which are definitely very common and very apt. Only one indication which interests me is vitreopapillary traction, which is not very common indication even among the VR surgeons. When do you say that I will go for surgery in vitreopapillary traction, and what are the signs that if you intervene, it will improve?
Initially itself, I will go ahead with the surgery if in case the disc margins are blurred in one eye and you see this obvious fibrous tissue which is pulling up on the retina. OCT helps as well. OCT can show that the disc substance is lifted up because of the fibrous tissue. If you are doubtful if that is what is causing it, then I would not intervene in the initial setting. So I will follow up this patient to see if these are the patients who don't have a macular reason for decrease in vision. If possibly, we can do an VEP, and then subsequently 3 months later repeat the VEP and then repeat the OCT to see if the vision is less, VEP is worse, and the OCT worsens, then we operate.
Mainly the OCT around the disc.
Yes.
OCT around the disc, vision during the follow-up any deterioration.
Sure.
And no macular or peripheral lesions.
That's right.
Thank you very much for this. And we came to this end of this National Symposium on Diabetic Retinopathy, which is very, very common clinical challenge every ophthalmologist face. It is not retina specialist area at all. Every ophthalmologist has to tackle, and I thank each speaker who contributed immensely to this subject, and I thank Piyush for staying all around from AIOC, and a lot of promise he has.